Welcome to Journal of. All right. Hello, everyone. Welcome to Journal of Cardiac Surgery's March Live Talk. My name is Irbaz Hamid, and I am an integrated cardiothoracic resident at Yale, also an associate editor of the journal. We're joined today by several renowned faces in cardiothoracic surgery, cardiac surgery. We have in our presence Dr. John Puskas from Mount Sinai. We have Dr. Faisal Bakin from Cleveland Clinic, and our own journal team. We have Dr. Thomas Herleno, who is the editor-in-chief of Journal of Cardiac Surgery. We also have Dr. Mario Gaudino from Cornell. We have Dr. Gianluca Torregrossa from University of Chicago. Welcome, everyone. We're also joined by our viewers from Twitter and YouTube. We'd also like to welcome them as we begin this conversation. Thank you, everyone, again.
Thank you. And I start this conversation that wants to be friendly among all of these leaders in coronary surgery by remember, first of all, to all of the audience that you guys can ask us questions. We want interaction from the people who are looking at us right now. And the first question is for Dr. Thomas Salerno, our editor-in-chief of the Journal of Cardiac Surgery, and for sure one of the pioneer of the off-pump coronary artery bypass grafting. So, Dr. Salerno, can you please tell us a little bit of history of off-pump? How did it start? When did it start, particularly for the north of the United States?
Good morning, all. Thank you for participating in this meeting. As you know, I'm the editor-in-chief of the Cardiac Surgeon. I'm very grateful to all of you who contribute and participate in this meeting. The history of cardiac surgery, particularly in coronary vascularization, is fascinating. I was very fortunate to be able to have worked with Dr. Arthur Weinberg, which you all know. Weinberg was a pioneer and spent his life doing memory artery to the LAD. I was his resident at the time. After Weinberg operation, Goetz in 1961 bypassed the rima to the right coronary artery. That's probably one of the first off-pump coronary artery bypass surgery. This was followed by Kolesov, but who did also a lima to the LAD via left thoracotomy. In Canada, Bizarre and Trappa in 1975 performed a coronary artery surgery, present a series of patients without a heart-lung machine. As you know, Favalori in the Cleveland Clinic popularized on-pump. Buffalo and Benetti, which I know very well, are the pioneers on off-pump coronary artery surgery. I was very fortunate to have worked and seen and become friends with both of them. They are actually the pioneers, the father of off-pump coronary artery surgery. And then Calafiore developed the so-called LAST operation. This was based on work by Benetti. LAST means the left anterior small thoracotomy. And then later on, Angelini in England did the hybrid approach, which you do a stent do a lima to the LAD and stent the other coronary arteries. A procedure that, in my view, is coming back. So the history of off-pump coronary artery surgery to me is fascinating. In the 80s, I became very interested in this. I began to realize that coronary artery bypass surgery is an operation that does not require the heart-lung machine. And my attitude was, I will never use this heart-lung machine again if I don't have to, and this has been my practice. This is a summary to give us a lot of time for discussion of my history as I lived through it with the off-pump coronary artery surgery.
Excellent. So the off-pump and on-pump has been basically one of the most discussed topic in coronary surgery. And I would like to have the opinion of Dr. Faisal Bakin from Cleveland Clinic. What is your opinion about off-pump and what is your practice? Do you practice off-pump? What are the reasons that make your choice the technique that you generally adopt in your coronary strategy?
Well, that was a nice summary by Dr. Salerno, and we've been following his work and the work of others, including Dr. Puskas. And they have demonstrated to us over the years that off-pump in the hands of capable expert surgeons can achieve excellent outcomes. And we look at the data and we base our practice on the data and the experience that we have. At the clinic, Dr. Sabik did a randomized trial, small randomized trial, that did not show any difference between on and off pump CABG outcomes at the clinic. It was a small study, but nevertheless, again, demonstrated the safety of off pump CABG and its efficacy. Having said that, we practice off pump selectively at the Cleveland Clinic. We offer it where we feel that it might actually benefit the patient. We do it when we obviously perform a mid-cap CABG. We do it when the ascending aorta is diseased. We do it when we really believe that the physiologic insult of the pump may be detrimental to the patient. For example, a cirrhotic patient. Other than that, the kind of patients that we get referred, the severity and diffuseness of the disease, the poor quality of the targets, remember, we're a quaternary referral centers, makes the operation a little bit easier and probably more thorough and precise with an on-pump technique. So as a default procedure, we use the on-pump technique, but in select cases, we use the off-pump technique. Now remember, Dr. Favaloro did his initial CABGs off-pump, but then he cautioned us by saying that if you're going to do this operation precisely, if you're going to do complex constructs, then he recommended against the off-pump CABG technique. But he also had a disclosure, that is, that this operation can still be performed probably safely and effectively in the hands of the few experts. And he was an expert, but he was a humble expert.
I like this definition of a humble expert. So I'm going to reuse it. Dr. John Pascas, I've been one of your trainee, and before meeting you and spending hours in the operating room with you, I've always thought that off-pump coronary bypass surgery didn't allow you to do a good job with your distal, particularly when it was very difficult. But you completely changed my mind, because I saw you and I learned from you how like an ATO can be easily used even in an off-pump setting, and the quality of the anastomosis does not get affected. What is your personal story with off-pump when you have been started to get involved, and what is right now, if you have to say a percentage of off-pump versus on-pump in your practice, what do you think is the role of off-pump in the coronary world right now, in your hands and even in the hands of the general cardiothoracic surgeon that is not an expert in coronaries?
Thank you, Gianluca. It's a pleasure to be part of this panel, particularly because on the panel includes Dr. Salerno, who showed me the very first off-pump anastomosis that I ever witnessed while I was still a trainee in the early 1990s, and also to participate with people like Mario Gaudino and Faisal Bakin, who have written and thought more deeply about coronary surgery than the vast majority of our professional colleagues. Gianluca, you and I have spent a lot of hours, not just a few hours, together doing off-pump bypass. And sometimes we've stood on one side of the table and sometimes on the other side of the table. And you've learned that it is possible to teach and to learn off-pump bypass, but it's not easy. And I think that challenge of training even a highly motivated and intelligent resident to do a perfect job with off-pump bypass, that challenge is real. And I still struggle with it. Every 6 months we get a new resident, and it sometimes feels like Groundhog Day. It's a tough first few weeks for both of us, especially me. It seems as I get older, I tolerate the anxiety less well. But that said, my initial exposure to off-pump bypass was it had just become noticed and known in the early 1990s. I finished my fellowship and decided that this was what I was going to master this. It was actually one of my mentors, the late Dr. Ellis Jones, who was an exceedingly meticulous surgeon, an extraordinarily meticulous surgeon. And he taught me coronary surgery on pump. And there was to be no deviation from his technique. and I mastered that technique to his satisfaction. And then he said, you know, this off-pump bypass thing is coming along. This guy I know, Salerno, is doing it. I think you should go and watch him, and then you should do it. But you've got to be sure you can do it as well as you do it with me on pump. And so that was the challenge, to master off-pump surgery as well as Ellis Jones mastered on-pump surgery. And that's what I devoted the next few years of my life to doing. And as you know, we are uncompromising, and I think that's key. The issue really boils down to setting up the operative field, and in particular the anastomotic field, in such a way that you can accomplish exactly the same number and precision of anastomoses as you would do if the heart were arrested. And I think that really is the take-home message. Off-pump bypass should not be more difficult to sew than on-pump bypass. You simply have to get to that point where you can manipulate the heart, rotate and displace the heart, and then stabilize the coronary artery in such a way that the anastomotic sewing is actually an afterthought. That's just exactly as you would do if there were a heart-lung machine behind you. And I think that's what people don't adequately understand. It's not about the sewing. It's about getting ready to sew.
Mm-hmm. Yeah, totally. That's an excellent comment, and I echoes that is not about sewing, but is the preparation that is behind before doing it. Mario Gaudino, it's your time to give us your perspective, and that is, as always, a scientific and literature-driven perspective about off and on pump. What do you think we have investigated for years on versus off, so asking you to summarize the literature in 2 minutes is a kind of a scientific challenge, but what you can tell us about this procedure from a scientific point of view, what has been published?
I think, Gianluca, one point I want to make, which I think would be incredibly important for everybody that is listening to this conversation, but in particular for young surgeon, is that while John was speaking about his early experience with CABG and how he learned the technique, but then he wanted to make sure that the technique was at least as good as the traditional technique. Well, the way John did that was through a randomized trial. And John did the SMART trial was actually the first large-scale randomized trial comparing the two interventions. And this is really a beautiful example of how we as a surgeon should be open to innovation, but also able to test the innovation using the best possible methodology, which is an RCT. So this is clearly a testament to John, but in general, an example for all cardiac surgeons of how innovation should be addressed and managed in cardiac surgery. Well, there have been more than 100 RCT comparing off and on pump surgery. I think that if we want to summarize the evidence, experience definitely play a key role in the hands of experienced surgeon. The result of off-pump are comparable to that of on-pump surgery. There is some signal that suggests that there may be early benefit for off-pump regarding renal and respiratory function. It's possible that the benefits are even larger in a selected high-risk group of patients. That has not been proven yet. It's also true that there is also evidence that in the hands of a less experienced surgeon, the result of off-pump may be worse than the result of on-pump, even regarding important clinical outcomes such as death, MI, and repeat revascularization. So it's not a yes or no answer. As always, it's a little bit more subtle and complex answer, but I think this is kind of the summary of where we are.
Thank you. I think it was an excellent summary, and I want to start to have a very a casual conversation. That's what I like, where everybody can join and put their point of view here. I think personally that by relooking the literature, we have two incredible settings that off pump gave us advantage with. The first one is that when combined with the use of bilateral internal thoracic artery as only inflow for your heart, you can avoid to manipulate the ascending aorta. And I think that in all of the literature, in all of the randomized trial, we as cardiothoracic surgeon involved in off pump have done a bad job in protecting the ascending aorta and the manipulation of the ascending aorta, meaning that the side clamp does not help the results of stroke respect and an on pump and cross clamp heart type of surgery. The second setting is the minimal invasive that Dr. Thomas Salerno was aiming before. If we want to still maintain a role for LITA to LAD in minimal invasive setting or for bilateral internal thoracic artery in minimal invasive setting, off pump is a key. So Dr. Thomas Salerno, tell us a little bit more about your experience with the proximal anastomosis, how you do it. What is do you side clamp the aorta? Do you use one of these devices of like heart string devices? Where do you think is the current perspective and the future of it?
During my young days when I was doing conventional on-pump coronary artery surgery, I think you know that I reported a single aorta cross-clamping technique for coronary artery surgery, in which I did the whole operation with the aorta cross-clamped. The purpose of that paper was to improve myocardial protection. I thought that the coronary stenosis, when you took the clamp off, the heart would be ischemic, and was extrapolated to preventing a stroke for not applying the side bite clamp in the aorta. Lima to the LAD is the most important part of this operation. If you do Lima to the LAD, the patient probably, and there is flow, the patient's probably going to live a normal life. Obviously, as you mentioned, the advance of bilateral memories also improve the outcomes, in particular by manipulation of the aorta. I basically right now in my practice, I put a side clamp. But however, having said that, if the epic aortic ultrasound shows disease in the ascending aorta, we use the heart string. For those of you who do not know, before you start putting heart string, you better find out the cost of this little device. Which is the price of the operation. It's more than what you make for doing the operation. So I don't have any real secrets by eliminating the side clamp. I just want to make a comment because people always ask me that. What is the indication for coronary artery, off-pump coronary artery surgery? I think it's coronary artery disease. I basically took the attitude from the very beginning that I'm not going to put these patients on a heart-lung machine. And so I go years without putting a patient on a heart-lung machine. I have no selection. I operate on everybody without a heart-lung machine. I don't know if you want to show the slide, my video now, but you can show it later.
Yeah, this is one of the video that you share with us.
As you can see, this is very primitive. I still use the vaginal pack, the original description, the Puska, and the other saw in Buffalo. I haven't changed. And then you can see the other video, the other picture, and when you come to my operating room, what you see for a coronary artery bypass is the next slide. I hope I don't want to take the thunder out of the presentation, but
no, I'll do it in a second.
Okay.
So while you do that, Gianluca, I can tell you that a very, very, a standard conversation between Tom and myself, we speak very, very often because of the journal. And so if Tom called me and it's like, and I thought, I was in the OR and John and Tom first.
The next one.
Tom very first comment would be, you haven't used the pump. Did you? So that's a typical Tom Salerno vision of coronary surgery.
This is the circumflex picture that you see. I didn't have a movie to show you. By the way, they asked me before, what is the most dangerous artery to do is the Lima to the LAD. What is the easiest artery to do as safest is the circumflex. and the right coronary artery is also difficult, sometimes risky, because you can have heart block. So if you're doing off pump, you do Lima to the LAD, then the operation is finished. Everything else you do could be done by stents. Can you show the other picture? I sent you a picture, did I not?
This is
Here it is. This is Salerno in the operating room, a dental tray. I don't have anything else. I have a blower, forceps, needle driver, and I need an assistant to blow. That's it. I really simplified this operation.
That's an excellent try. I will never be able. I'm too spoiled to operate with so few instruments. I'm very meticulous and particular about my instruments. But Dr. Bacchina, we are here to talk about low ejection fraction patients, and we will ask soon about the off-pump techniques to the off-pump surgeon here. But what is your technique in a low ejection fraction? Let's say that there is a patient. He's 65 years old. He comes with a stable coronary artery disease. His ejection fraction, though, is 25%. He's deemed to be appropriate for revascularization. You did all of the tests. You have all of the viability, and you wanted to do his surgery. Which graft do you use? How do you do him? And which techniques or which tricks do you use for your low ejection fraction patients that you can share with the audience?
Thanks, Gianluca. I'd like to just make a brief comment about the instrument set, the cheap instrument set that Dr. Salerno, cheap but effective set that he uses. Dr. Cosgrove, when he was the chairman of the Department of Thoracic and Cardiovascular Surgery at the Cleveland Clinic, when they started doing off pumps, he actually did a cost analysis and financial analysis and found out that doing the procedure on pump was cheaper than off pump because you didn't need a special retractor, you didn't need a stabilizer, and the procedure went much faster doing it on pump versus off pump. But anyway, that's the historical, things have changed over the years, but that's the historical anecdote, if you'd like. Now, with regards to the current strategy, I think the most important thing, as you pointed out, is in the workup of the patient. The first question that I ask is, how did the patient present? Is he a patient that I'm seeing in my office in well-compensated heart failure? Or is it somebody in-house in the CCU on inotropes, plus or minus a balloon pump, plus or minus an impeller? That's important. I think the physiologic status of the patient is an important consideration. The second big question is the anatomic considerations. And the most important question is the quality of the targets. Now, in the article that we reviewed that was published by Dr. Salerno, those targets were beautiful targets. And that's very reassuring. When you see a chain of beads, when you see poor quality targets, when you see the possibility of incomplete revascularization, that's what concerns the surgeon. The next anatomic factor that I look at is the size of the LV. If the LV is massively dilated, if it's thinned out, I mean, I know we have a viability study, but I also look at it visually, anatomically, versus a ventricle that's still thick, that's small. That makes a big difference. And then the right ventricular function is often a variable that people don't talk much about, because if it's a biventricular issue, then that's a totally different ballgame, because the RV might not reap immediate benefits from revascularization like the LV does. But anyway, assuming that this is a well-compensated patient with favorable anatomy, you could really approach it in any way you want. My preference is a quick on-pump with excellent protection, meaning you give antegrade, retrograde, and down the graft, short cross-clamp time, complete revascularization, and that patient will do well. Now, others might advocate an off-pump approach, which is perfectly reasonable. Others might recommend placing an intra-aortic balloon pump and doing it off-pump. That's fine too. But if that patient, on the other hand, is decompensated, I would spend some time doing a complete workup, putting a Swan-Ganz pre-op, optimizing his hemodynamics or her hemodynamics, plus or minus place a mechanical support pre-op to reverse other organ dysfunction, and then take them and do a complete revascularization, plus or minus other adjuncts like a mitral valve repair, etc.
Very good replies. And a very quick comment. Do you use arterial conduit in low ejection fraction in a patient, let's say 65? Do you still use it? Are you worried after surgery that you have to use inotropes or pressors in these patients? And does that change your attitude towards an arterial conduit? I love, please everybody focus on the face of Mario Gaudino right now on this question.
Well, to please Mario, I'm going to say I'm going to do all arterial, but no, I'm not. I think I'm going to do a lead to LAD unless it's a really extreme circumstance. I think the lead to LAD is key, especially for a young patient like this patient who's 65. Would I use another arterial conduit? Well, I tell you what, if he's has no heart failure symptoms and he's got an important OM or circumflex target or an important right coronary target, which, and I mean by important, is that it supplies a huge myocardial territory, then yes, I would consider that, especially if it's not a high predominant wraparound LAD. Because sometimes you get a LAD that barely reaches an apex, and then you get a huge OM. In that scenario, you may want to consider using a RITA. Using a radial is possible, but I would get a little nervous if I think that they're going to need vasopressors in a significant amount in the perioperative period. So in summary, it does not rule out using multi-arterial grafting.
Faisal, I thought you were not using the radial at all at the Cleveland. I'm surprised that you used the radial. I thought you was a beta only guy. No,
I follow your work, Mario, and I started using the radials. And actually, I did probably most radials than anybody in a randomized controlled trial. I enrolled 70 patients in the VA study with 733 patients that was published in JAMA back in, I think, 2011. And I was very pleased with my radial outcomes. But I harvested, with the radial patencies. But the only difference was that I harvested every single one of them, and they were beautiful, none bruised, and I haven't had any adverse events related to the outcomes of the patients enrolled. What makes me nervous is that when that radial is harvested in a less delicate technique, they really become finicky, and the outcomes become so unpredictable.
Very well. Dr. John Pascas, give please your recipe. Low ejection fraction patients, which technique do you use for off pump? How can we, like a young surgeon is starting his practice in off pump, is committed to do so, how can you do a safe off pump in low ejection fraction? When do you convert, or when do you suggest, or is there anything you can do before you convert? And finally, a little bit about graft selection. What do you use? I know you're your use of multi-arterial when we were together was 98%. So please.
Thank you. To me, the issue of low ejection fraction patients really depends upon their hemodynamic stability in the operating room. As I said earlier, in my mind, off-pump bypass is about getting ready to sew. And most patients with low ejection fraction, if we use all the right maneuvers, the opening of both pleural cavities, division of the pericardium off the diaphragm, elevation of the edge of the sternal retractor, the deep pericardial traction suture or slings, the starfish, all the right maneuvers, you can usually expose each of the main coronary arteries in a way that maintains hemodynamic stability and allows you to construct a perfect anastomosis, but not always. Some patients with low ejection fraction also have mild ischemic MR. And if you pick up the heart in some of those patients, that mild ischemic MR will get to be moderate or moderate to severe MR, and you can have a downward deterioration. I think it's important to recognize that off-pump bypass is not a religion. It's a technique to accomplish revascularization. And I think that the heart-lung machine is better than shock. It may be that OpCab is better than the heart-lung machine, but it's clear in my mind that the heart-lung machine is better than cardiogenic shock for a prolonged period of time during an off-pump bypass in a patient with low EF and poor manipulation or imperfect technique to expose the heart. So if I cannot maintain good hemodynamics with a sort of test of exposure, and I cannot think my way through a strategy of sequential revascularization that would lead to avoidance of worse ischemic MR, for instance, then I'll put that patient on bypass. And I think that if I can make that decision early, before I've begun any anastomosis, I think of it as no blood, no foul. I haven't done anything wrong whatsoever if I've chosen to put the patient on the heart-lung machine prior to beginning an anastomosis. But if I find myself with an open coronary artery and, deterioration in hemodynamics, I feel I've made an error in judgment or an error in technique or both. Because that's a conversion. And yes, you can put the shunt in place, you can put the heart down, you can achieve some stability and convert in a quasi-elective way, but that event is not good for the patient. Now, there are a few patients who have, clear contraindications to the use of the heart-lung machine, and we know who those are. The most dramatic is the porcelain aorta. In that scenario, we would use the double mammary grafting and radial or vein off the double mammaries, and we would sequentially graft those vessels that can be accomplished with this technique, because going on the heart-lung machine is not one of the options. But neither is crashing onto the heart-lung machine for that patient. So you've got to maintain hemodynamic stability. In terms of choice of arterial conduits, it's rare, really rare, that we don't give at least 2 arterial grafts to every patient. And the majority of patients get all arterial grafts in our operating room. Thursday was 2 days ago. I did 3 off-pump coronary bypasses. The sum of their ejection fraction was about 65%. And they were all off bypass, but none of them were easy. The residents didn't get to do the lateral wall grafts. 2 of the 3 were double mammary. One was, and all 3 had a radial and a lima. But it was a tiring day in the OR. All 3 were extubated within 6 hours, but neither one left the ICU the next day. They all need an extra day in the ICU because they're people with ejection fractions of 18%. And, you're spending time diuresing these people post-op. I think that off-pump bypass clearly has most benefit in patients for whom on-pump bypass will be challenging physiologically or anatomically. And that's the patient where we should really go the extra mile to achieve the operation off pump. It's unequivocal that there are some patients for whom it doesn't make a big difference. It's certainly not in terms of mortality risk. There are other benefits of off-pump bypass. Reduction in blood loss and transfusion has been demonstrated across literally every randomized controlled trial. And if you can just say that this technique achieves similar revascularization, but cuts your risk of blood transfusion by 50% relatively, then clearly that's an advantage of the off-pump technique. But in my mind, it's avoidance of stroke and neurocognitive injury that is the most compelling reason to do off-pump bypass. And, I think, as Gianluca alluded to earlier, the biggest mistake we made advocating for off-pump bypass for the first 15 years was putting a partial occlusion clamp on a pulsatile aorta and thinking that would have less thromboembolic or atheroembolic stroke risk than a single clamp on pump. I think, frankly, a careful cannulation and a single cross clamp will probably not produce more emboli, or not importantly more emboli, than a partial occlusion clamp on a less than perfect aorta. So we have not used a partial occlusion clamp in almost a decade, whether we're on pump or off pump. And so I'm talking about 3,000 at least consecutive coronary bypass operations. And I think that's an important message. Off-pump bypass will not achieve the stated goal of reducing neurocognitive injury if we use a partial clamp. That doesn't make sense. It was my mistake, as well as the mistake of others early on in advocating for this technique. But that simply doesn't make sense.
Sure. Thank you. These were very important input. And I think personally that in my experience, I gave also a lot of credit to the person who is in front of you. As Dr. Pascas was saying, right now when I work with a resident myself or with a junior PA, that is not the day in which you want to do a difficult off pump, because off pump is more a team sport where you need to have in front of you different type of skill set, someone that has the mindset, and not only in front of you in the operating table, but also on your side, meaning on the anesthesiological side. If the anesthesia is the resident and the attending is used to take his cup of coffee, and spend all of his days smoking his cigarette until when the cardiopulmonary bypass is off, that's not the OR in which you want to start your off pump, because you need the big team in the off pump is the surgeon with the anesthesiologist. It's a big team that you have to work on. So you need to have a culture in your center or in the place where you are to start your off pump technique. I've always been fascinated by the fact that there are subset of patients, as Dr. Pascas was saying, porcelain aorta. Dr. Bakina was referring before, cirrhotic patients, patient in which maybe Jehovah's Witness, you don't want to bleed too much, you want to stay off pump. But off pump, as everything in surgery, if you don't do it frequently, you are not going to do it the first time in the most difficult case. That is the liver cirrhotic guy with a MELD score of 12 that comes in your OR, and you are really worried about drama after surgery. So, Dr. Thomas Salerno, how can we imagine to start to teach or to adopt off pump if you don't do it on an everyday?
This is the major problem of reports in the literature of surgeons who are not comfortable or don't do off pump very routinely. I think if you are going to become an off pump surgeon, you need to have this attitude that the heart-lung machine is not part of this operation, except when you're flying the 747, you have to jump off the parachute. That will be different. But jumping off a parachute in the 747 is very rare. I'm sure John agrees with me that going crash on pump is actually rare. You usually can predict by looking at the heart that you're in trouble. And a lot of things you can do to prevent that. If you came to my operating room, I usually have a resident in anesthesia. In front of me is a medical student. We're listening to music, joking, doing this off pump. We made it extremely simple. I just want to go back a little bit to the PURI-F function. I have had a different attitude about coronary artery surgery. I'm going to share with you. I'm embarrassed to say that. First of all, I told Mario Galdino that one day I'm going to take his radio artery, even though he's a heart surgeon. He says, mine you will not take from me. I said, well, then why you're taking from your patients? So that's the first thing. The second thing I realized is, whether you like it or not, this operation is lima to the LAD. And when this came about, lima to the LAD, minimum invasive, when I was doing in Buffalo and published some of that stuff with Calafiore, the biggest enemy of minimum invasive coronary artery surgery were the surgeons. We had an opportunity to do lima to the LAD, have the cardiologist put stents everywhere. And we didn't. A dilated heart or a PURI-F patient, I'd rather operate on that patient. And if you make the incision the right place and the cardio open in the right direction, when you open the sternum, the LAD is in front of you. You don't have to do anything. You have to stabilize it and do lima to the LAD. In my mind, I measure flows. If you're not measuring flows, you're going to land in the wrong airport, as Mario Galdino reported. We have high technology, and this pilot landed in the wrong country, the wrong airport, despite all the technology. You're doing surgery with loops, and you don't measure flows. So how do you know that artery is open? So if you do lima to the LAD, in my mind, the operation is finished. The rest, I can do whatever you want, but basically that patient will probably survive. The last thing I want to tell about teaching, I always operate on the assistant side. I do this operation from the assistant side. So whoever is on the other side, the resident, whatever, they think they're doing the operation. I'm just moving the table around a little bit, but I'm always on the assistant side. One of the problems of off-pump is that I trained a lot of, because I don't do coronary artery surgery on pump. I've trained a lot of surgeons on off-pump, residents. When they go to any centers, the first thing they say is, here we don't do off-pump. That's the end of it. Which to me, that's very sad. And because of this, it's I appreciate very much, John, that you now have this fellowship in off-pump coronary artery surgery, because that will probably improve the number of cardiac surgeons who are doing this operation.
Yeah, let me make a pitch for that, Tom. We have founded, and we have 2 positions annually at Mount Sinai Morningside, an advanced coronary surgical fellowship. So this is an opportunity for specialty training in advanced coronary surgery. We're looking for people who are finishing an I-6 program or a conventional 5.2, 5.3 program and want to dedicate at least 1, perhaps 2 years to mastering the state-of-the-art in surgical coronary revascularization. We will not make you an expert in repairing or re-repairing the Barlow's mitral valve. We will focus solely on coronary surgery. And we take 2 fellows per year. We've got 2 good fellows now. We're more than willing to accept international fellows as well. I think that we have to focus on coronary surgery as a super specialty, not a subspecialty, but rather a super specialty of cardiac surgery, because I think without a doubt the technical challenge of advanced coronary surgery exceeds that of any other procedure we do in all of adult cardiothoracic surgery.
So I have 2 questions. One is from a young surgeon's perspective or a trainee's perspective. I think we've all, in different lights, spoken about the role of off-pump CABG for young cardiac surgeons. What, in your opinion, should be the approach that young cardiac surgeons or trainees, what approach should they take to learning off-pump coronary surgery? Dr. Puskas described the fellowship training. Dr. Salerno also described how some places totally do not practice off-pump surgery. Dr. Gaudino mentioned how experience is key for good outcomes to this. How do you see the learning curve for this and off-pump surgery fitting the practice of a young, freshly graduated cardiac surgeon? That is the first question that I have, and then I will take a second one from the comments. But if we can shed light on this, please.
The first thing is don't try to learn this operation. Pick up from where Mario, Gaudino, Pushka are. Visit them, see how they do it. If Pushka has this super fellowship, be ideal. But you don't have to learn to start from zero. You can pick up from where you are, where we are.
I would agree with that. I think that for a young surgeon, if you've just finished your I-6 and you have your first job in private practice, and those surgeons don't do off-pump bypass, and you've never seen one or you haven't been formally trained in it, trying that out in your first few cases in practice is a prescription for having a very brief practice. I would not do that. I think it does require specialized training. There are centers that begin and end their training with off-pump bypass. I'm thinking particularly of Paul Sargent's program in Leuven, Belgium, where generations of residents have never done on-pump coronary surgery, and they've done hundreds of cases. I think residents should strive to learn the technique in an academic way. If I have had a resident in my OR and I've shown them 3 times exactly how I do the LAD, the diagonal, the marginal, the PDA, I expect that they have written down and memorized exactly how those stitches are passed in the conduit and in the coronary target, so that when I hand the needle driver to them on the 4th case, they should not look as if they'd never seen this before. They should have been at home practicing, whether it's on little silastic tubes or whatever, but the manual task of sewing seems to consume the imagination of the trainee much more than it should. That should be a brainstem function, something they practice so many times at home on little plastic tubes that Jim Fan and others will sell to you online for a nominal fee, that the sewing, that the operation in the operating room is much has a much broader perspective than just the focus on, gee whiz, Dr. Puskas, how did you put that third stitch in on the diagonal? Well, watch, for goodness sakes. Write it down and memorize it, and then practice it till you can do it asleep. Then you can do it on Mrs. Smith. Mrs. Smith did not come to the hospital to teach you how to put the third stitch in the diagonal. Mrs. Smith came to the hospital to have a perfect heart operation. You should learn how to do the third stitch in the diagonal at home on a piece of plastic. So approach this with, I'm going to learn exactly how my mentor sews, and I'm going to replicate that perfectly. Then I'm going to learn how to rotate the heart and maintain hemodynamic stability, because I will understand the inflow to the right side of the heart, the outflow from the right side of the heart, the inflow to the left side of the heart, and the outflow of the left side of the heart. And I'll understand the constraints of the pericardium and the diaphragm and the sternum. And I will think through this 1,000 times in my own mind and practice that mentally before I sew that stitch in Mrs. Smith.
Thank you very much, Dr. Puskas. I can appreciate the comments you made as a young trainee. I've started writing down steps, but I really liked how you described that the sewing should not be the focus, and that should be something that is natural, is your brainstem that's making it happen, and you focus on the actual substance of the surgery. And I think that's a very key takeaway for all young trainees and new cardiac surgeons. Thank you very much for sharing that. I have a second question here from our comments. When do you prefer complete revascularization versus partial revascularization? And is that even a consideration when you do off-pump CABG? Dr. Salerno, Dr. Puskas?
Cardiac surgery, coronary bypass studies have for generations now clearly demonstrated that complete revascularization predicts better survival than incomplete revascularization. And some of the most elegant studies actually have come from Faisal's shop in Ohio. A really nice study relatively recently that stratified outcomes with patients, whether they're on or off bypass, single versus double mammary, complete versus incomplete revascularization. The worst surviving patients were those who had an incomplete revascularization with a single arterial conduit. And the best surviving patients were those who had a complete revascularization with at least 2 arterial conduits. And I think that those rules apply in the vast majority of patients. We would only do incomplete revascularization in an exceptional candidate. Now, we do hybrid revascularization. So a patient who refuses a sternotomy or has a classic sort of 2-vessel disease with a very easy type A stentable lesion in the right coronary and a complex calcified lesion in the ostial LAD. That patient will likely, in our hands, receive a robotic minimally invasive LITA to the LAD, and either before going home or at some interval in time, come back to the cath lab, have an injection of the internal mammary to confirm patency, and then a stent in the right coronary. This is a planned hybrid approach. And while you can call that incomplete revascularization, it is actually just a different revascularization strategy.
So cardiac.
Go ahead, Tom.
Sorry. No, go ahead. Go ahead, John. Finish.
So Tom had commented on the sort of over the outsized, the dramatic benefit of an internal mammary graft to the LAD, which is very real. I don't agree entirely that the right and circumflex, are sort of throwaway vessels that we can stent, because to be honest, we actually see a few patients who come back with, full metal jacket in the circ and right, ischemic MR, and no disease in the LAD. And gee whiz, Dr. Puskas, you coronary specialist, what are you going to do now? And that's a tough patient. So I would rather get arterial grafts everywhere at the first go rather than one arterial graft and a bunch of stents. But it's also true that for a frail patient, or even the young patient who is a laborer and wants to get right back to work, a robotic bypass to the LAD and a stent in a type A lesion in the mid-right coronary, I think that's a pretty good operation. That patient will leave the hospital in 3 days and be back, at work on a construction site in 3 weeks instead of 3 months.
Yeah.
And for some patients, that's the difference between, being able to put food on the table and not being able to. So I think there is a role for hybrid revascularization. It is not a replacement for multi-arterial bypass grafting in patients that really need 5 grafts. I view hybrid revascularization as an alternative to too many stents, not too many bypasses. I think that procedure should take patients out of the cath lab and put them in the OR and at least give them the benefit of a lesion to the LAD in a patient population who otherwise wouldn't even have a surgical consultation.
Yeah. Excellent question, and I want to take from here and adding some of the questions that we have also from our viewer. For example, Peter Vidal is asking, do you prefer a complete revascularization or a partial one? And again, Ricardo Lima is asking about myocardial revascularization, the central role of Lima to LAD. And here we are taking something that really fascinating me right now. That is the concept of partial revascularization versus multi-arterial revascularization. Meaning, and this is a question directed to Dr. Bakin, because I'm a big fan of his publication and I follow his beta grafting survival, even in incomplete revascularization, as Cleveland Clinic has showed, can be even benefited than single internal thoracic artery with complete revascularization. So should we consider, and as a fascinating person in robotic, I'm wondering, should we consider in reality that there is a huge patient population that just would benefit from 2 mammary artery harvested robotically from the left side of the chest, deployed on the left coronary artery, the best 2 graft, the best 2 targets of the left coronary artery system, and then stent the rest? And again, I'm not saying all of the patients should receive that. I'm not saying we should replace the sternotomy CABG with that. That's not my approach. But there is a huge gray zone of patients with stable coronary artery disease. They come for elective CABG that should be served in this way. What do you think, Faisal? Give us some input.
Yeah, I think the key here is to achieve a safe and effective operation. The most important component is the ITA to the LAD. And the more important, the more dominant the LAD is, the more the benefit of that ITA to the LAD. Now, if you have another big important target, then that target warrants the use of a second ITA or radial for that matter. Now, whether you do this robotically, on pump, off pump, is really the surgeon's preference. The most important thing is what's the final outcome. The immediate outcome has to be excellent for the patient to have any long-term outcome. So the mammaries have to be harvested meticulously, skeletonized, and without injury. And the anastomosis has to be perfect. The immediate outcome has to be perfect. And then the long-term survival would be secured. On the other hand, if you try and do things that you're not comfortable with, that are new to you, you're doing it for show rather than for the benefit of the patient, then that's the biggest mistake that you could do. And for the younger surgeons, it's important to master the basic techniques first, and then incrementally move to more complex procedures. So the specific use of a robot, I think some have demonstrated the safety and efficacy. Those series have been small. They've been limited to a single surgeon expert. And as Mario said, the gold standard of an RCT is lacking. So we would just have to go as surgeons and as patients with what data we have. So if surgeon X has excellent outcomes harvesting bilateral internal thoracic arteries with perfect patencies verified in the OR by flow meter or by follow-up angiography, CTA, or cath, then by all means, do it that way. Otherwise, just do it the way that achieves the safest and most effective results in your hands, because that's the most important thing. The surgeon has to take care of the patients, and the newer surgeons have to take care of themselves. They have to have perfect outcomes when they first start.
Very excellent point. So Mario, let's Dr. Gaudino and Dr. Salerno, let's put some extra pepper here before we go and close this conversation about the fact that yes, we have done off pump, yes, we have promoted off pump, but there's a lot to say about the finicky, as Dr. John Pascas was referring before, about this operation and the details. And one of them is assessing the patency of your graft after you have done it. And I think that if you are, and this is perfectly in line with what Dr. Bakin was just saying right now, if you are an off-pump surgeon, and even if you are an on-pump surgeon, you must use a transit time flow Doppler graft assessment, whichever you like, whichever your hospital has. But what is your input about it? Why we are not using it? Why it's so difficult to convince a cardiothoracic surgeon to buy a little probe and to put around the coronary for a minute after their surgery? What is the big deal here? Why we can't educate surgeon anymore?
Well, I'm sure Tom has something to say about it, but my hand. Let me say, Gianluca, I don't know. I don't understand it. It's just something I don't understand. I was trained with the idea that you need to check the flow in each anastomosis, and it seems natural and logic to me. The same way you want to check that you don't have a leak when you do an AVR, or that your mitral repair is working with TE. So I wouldn't feel comfortable doing what I do without a flow meter. And actually, when I came to New York, my very first request, when they asked me to stay and to lead the coronary program, was to have a flow meter. I said, I'm not going to do what I was doing in Rome here without a flow meter. So it is as simple as that. And why people don't use it? Well, I am not sure. Maybe they are not. They are concerned that this may be difficult to read. As a community, probably some of the flow meter experts have made the flow meter reading too complicated, and so people may think that it's rocket science. Whereas I personally look at a couple of numbers, and I'm not very sophisticated in my flow meter reading. And then there may be some people that just don't want that prefer to have a blind eye, and they don't want to be in the situation where they have to admit that they have made a mistake or an imperfect anastomosis. But that is generally a bad strategy, because it will happen in the middle of the night, and so things will be worse. David Taggart is used to say that from the moment he started using the flow meter, he stopped getting that call at 4 a.m. in the middle of the night, telling that your CABG patient is crashing and you need to go back to the OR. And I think that's very true. You can get other call in the middle of the night, but usually for more pleasant reason. So I would say that we all should use the flow meter. And also, in general, Gianluca, my principle is that you don't ever to compromise.
I think Doug agrees with you.
Yes, I think Tom Doug agree. That's great. But in general, Gianluca, let me start by saying that you don't have to compromise the quality of what you are doing in the name of a technique. Like Faisal say, that's the biggest mistake you can do. You need to do a good operation. If you are a technical master like John, Faisal, you can do the stuff that they do. Great. If you can't, you are a simple surgeon like me. You just do whatever you are comfortable doing. But the bottom line is that in the end, you must have done the right operation for that patient, and you cannot compromise on the quality of the end product. And I like Faisal saying the long-term result cannot be good if the short-term result is bad. That's genius. Thank you, Faisal.
In my opinion, the patency of the Lima to the LAD is not 100% because surgeons don't measure flow and close the chest with the Lima occluded. There is no way you can know if there is flow if you don't do some control of the anastomosis, such as flow meter. One person asked, why do surgeons do not measure flow? So if you are a non-pump surgeon, you do Lima to the LAD, you come off pump, the patient is perfectly stable, normal wall motion, and you put your flow meter in the Lima to the LAD and there is no flow, you don't believe there is no flow because you're off pump. To redo the operation, you have to reclamp the aorta, recardioplegia, redo the operation. If you're off pump and there is no flow, you just take the anastomosis down and redo it. It is inconceivable that cardiac surgeons worldwide are not verifying that they have flow in any grafts when they finish the operation. I recommend the audience, when you read the manuscript on long-term patency of coronary artery surgery, if some form of control of the anastomosis was not done at time of surgery, in my opinion, you should question that study because you did not know if the grafts were patent when you closed the patient.
This is an important point. I think that doing coronary surgery without a flow meter is like doing mitral repair without a TEE. You can do it, but why the hell would you?
Yeah, totally.
The
agree.
other point I think is it's not just about the anastomosis. A graft can fail for multiple reasons with a perfect anastomosis. Tragically, the most common, I think, is, an injury to an arterial conduit during its harvest. And we talked about that earlier. To achieve great long-term patency and the real benefit of multiple arterial grafts, whether they're double mammary or radial or both, those conduits have to be harvested in an atraumatic way. We treat them with intraluminal and extraluminal papaverin and lidocaine and heparinized buffered plasmolyte and blood, to try to have them be as maximally dilated and as little prone to spasm as possible. But at the end of the day, if the mammary artery has a dissection flap halfway down its shaft, it doesn't matter how perfectly you sew that distal anastomosis, your flow is going to be poor. And you can interrogate that anastomosis with the imaging probe. And also you can interrogate the length of the conduit to see that it's not the anastomosis that's the problem. It's that dissection in the middle of the Lima that's the problem. And if that's the case, you can cut out that dissection and do a spatulated reanastomosis and save the day. But you can only do that if you provide yourself the information about where the problem is. So putting the blinders on and hiding the truth from yourself does not serve the patient nor the surgeon in the end.
Another reason for flow meter is it's not very difficult to bypass a vein instead of an artery. I recently defended a surgeon who did just that, and he did not measure flows because it's not standard of care. So it's not standard of care. How can you fault the surgeon?
So just want to ask, if you sew it to a vein?
What is the flow? How does it look like?
It would be like a huge AV fistula. But he doesn't measure flows at time of surgery, so he assumed they bypass the right artery, and later they have to plug the vein by cardiology. I want to ask Mario a question. Mario, do you think opening the pleura is part of a regular coronary artery bypass surgery? What are the negative effects of opening the left pleura? Because I talked to Calafiore, and he agreed with me that to take down the Lima to the LAD, you should not open the pleura because of its consequence. I want your opinion on that.
Yes, sir. I agree because I was trained by Antonio and we were taught not to open the pleura at the time of harvesting of the mammary. Now I must confess that it is not the same at Cornell because has been very difficult to convince resident and even other attending that have been opening pleura forever that it's possible to do the operation without opening the pleura. So I think there is some cultural issue, but yeah, I don't think you need. You can do the operation without opening the pleura and just putting a mediastinal chest tube. But in any case, Tom, I have learned during my training that you and Antonio are always right. So whatever you think, I agree.
No, come on now.
So I think we're nearing the end of our time here. Just one last question. We've had this conversation about flow meter and how it's not being implemented in certain places. How can what in your opinion are the limitations? What is stopping society and cardiac surgeons in general from adopting this? How can this be promoted? And if there's someone who wants to learn this, but they do not have some support, how can they learn how to implement this in their practice? And then we can sum up our talk for the day.
People believe that since you're doing it on pump, you don't have to use the flow meter. You only use the flow meter when you do off pump. It's a culture that needs to be changed. Perhaps one of our future meetings should be about this topic, which is a complex topic about graft control of the anastomosis. Mario's paper was an airline plane full of people with all the technology available in the cockpit, two very experienced pilots with air traffic control, ground control. They landed in the wrong country and in the wrong airport. And the cardiac surgeon is doing an operation that one simple suture misplaced means that this graft is going to be occluded. And he will not know because finger palpation means nothing. Hemodynamic stability means nothing, may mean nothing. And you are probably closing a patient that you subjected to a major operation without determining that the work you did. As John said, how can you do a valve procedure without PE? And to end my statement is, how can you do a coronary artery bypass without flow meter or any other form like SPY to determine that your grafts are patent?
Well, this was a great summary. Dr. Bakin, do you use flow meter assessment? Cleveland Clinic use it as a standard of care in every patient or no?
I use it routinely, and I agree that surgeons should be encouraged to use it. Don't be an ostrich. Face the news, deal with it there and then in the OR. That way you can sleep comfortably, the patient will do well, and everybody will be happy.
So, Mario, do you still open the left pleura? From tomorrow, I will start to do. I tried a couple of times to don't open the left pleura when I harvested the left internal thoracic artery when I was a fellow of Dr. John Pascas. But I mean, I always end up doing all attention pneumothorax that I identify when the patient has the chest is closed, or I always open really proximally there. So after saving almost a crash of the day and having Dr. Pascas extending my smile with an 11 blade, I decided to stop the activity right there and just open widely the left pleura. So give me your comment about it. I want to know.
No, it takes a little bit. I mean, you need to really separate first the lung from the chest wall, and I generally do that like the very first step of the aorta harvesting. It happens from time to time that you open it, but most of the time you can avoid it. Clearly, if you are not sure, it's better that you open it, because the worst thing that you want to have is a pneumothorax in the ICU and everyone looking at you like you are really stupid. I mean, it can be done. I'm not sure it make a huge difference, and I think whatever you're comfortable doing, it's okay. Regarding the flow meter, maybe John should close this very, very, very interesting conversation with some maybe you can give some anticipation about a new society that can probably help people that are interested in the field of coronary surgery by producing not only the meeting that has been a tradition, but also new document. And we are working on something for the flow meter, because I think the future for young surgeons who want to learn advanced coronary surgery are not lucky enough to have Faisal or John or Tom in their center. It's probably guidance to professional society. So, John, I do not know how much you can share, but maybe you can say something.
Thank you, Mario. As some of you know, Mario is the Secretary-Treasurer of the International Coronary Congress that David Taggart and I founded, I guess, 6 or 7 years ago now. We will proceed this year with creating the International Society for Coronary Artery Surgery, which will be the founding body, if you will, the organization that will conduct the International Coronary Congress annually. So this is an international society focused solely on coronary bypass surgery. And membership requires interest in coronary surgery. That's it. And the annual meeting will be focused on the minutia and details, the philosophy, the techniques, the outcomes, alternative management, preoperative, postoperative, intraoperative management of the coronary surgical patient. So we have had small sessions devoted to flow meter assessment, but I think that the whole topic of graft assessment is one that needs a deep dive at our next annual meeting, which will be in December of this year, in person in New York. So we look forward to lots and lots of participation. And many of the people on this call are part of that organization. We want all to be. It's a very inclusive organization. And as Mario said, we're interested in creating guidelines documents which will help to steer practice in coronary surgery globally. Our mission is to close the gap between common practice and best evidence in surgical coronary revascularization. So that state-of-the-art surgical coronary revascularization, with all of its nuances and variabilities, is more broadly practiced, more expertly, and more academically. And so we look forward to participation of all those on our call, attending the call and participating in the panel. It's a mission. It's international, and it's focused solely on state-of-the-art coronary surgical revascularization.
Excellent. So I think with this one, we want to conclude this session of 1 hour and 12 minutes that we had about off-pump, on-pump, coronary, trans-time flow meter, the importance of avoiding or to manage the proximal anastomosis, and most importantly, the dedication that coronary surgery require, and the fact that these fields require people that are embracing coronary surgery as a primary activity in their job. I want personally to thank Thomas Salerno as editor-in-chief of Journal of Cardiac Surgery for this opportunity to create this live talk, and to thanks all of the panelists today for their time that they've spent, and everybody who asked us questions through the various social media. Looking forward to see everyone for next month for our new site. And please feel free to pass by the online website of Journal of Cardiac Surgery to catch the last issue and the last news and the recent publication. Let's looking forward, and thanks again to everyone for being here today.